in each case discussion. And I think this will be helpful for you in the exams also. So, without wasting much time, I wish all the best for the program. I congratulate the team PG Club under the leadership of Wanda sir and the Trivandrum IAP branch for hosting this program. All the best and over to Sri.
Okay, thank you, sir. And now I invite Dr. Mohandas sir to few words and also introduce all the faculty also.
Travel ചെയ്യുന്നോണ്ട് കേൾക്കാൻ പറ്റാത്തതാണോ?
അല്ല കേൾക്കാമായിരുന്നു. Now Mohandas sir, please opening remark and introduce the faculty. Yes.
Okay. Good evening. I'm not taking much time. I would like to thank the Trivandrum branch for organizing this week's program, and also Dr. Shanavas and Dr. Sreelatha for agreeing to be part of this discussion, and Anagha for presenting the case. Thank you.
So we have two faculty, Professor Dr. Shanavas sir and Professor Sreelatha madam. Sreelatha madam is the HOD of Pediatrics at Alapura, and Shanavas sir is the Professor of Pediatrics at Trivandrum. So we can start the case presentation, and Anagha, over to you. You can start the case presentation.
ശ്രീജിത്ത് എന്നെ ഒരു co-host ആക്കിയേക്കോ, ആരെങ്കിലും ഉണ്ടെന്നുണ്ടെങ്കിൽ മ്യൂട്ട് ചെയ്യണം.
Am I audible, sir?
Yes, very good. Fine.
Good evening, all. I am Dr.Anagha, second year junior resident, Department of Pediatrics, SAT. Respected teachers and dear friends, let me start my presentation. I am presenting the case of Panchami, 7-year, 9-month-old female child, hailing from Kidimanu, Trivandrum. Date of birth is 3/1/2018. Date of admission was 3rd October 2025. Date of examination was 4th October 2025. Informant is mother and she was reliable. Child presented with chief complaints of cough for 5 days, breathing difficulty for 1 day, and abnormal movements with stiffening of limbs for 1 day. History of presenting illness: 7-year, 9-month-old female child with global developmental delay under follow-up, now present with complaints of cough for 5 days, insidious in onset, intermittent in nature, wet cough with white sputum, with history of vomiting following cough consisting of mucus. There was no diurnal variation, not associated with fever, no postural variation. 4 days after the cough, the mother noticed increased frequency of abnormal movements associated with stiffening of the limbs. Child had this abnormal movements since she was 3 years of age, for which child was on some medications, following which the symptoms were controlled. But currently, mother noticed increased frequency of this movement, and the mother describes this as twisting movements involving both the upper limbs and lower limbs, lasting for few minutes, more towards the daytime, not associated with uprolling of eyes or tonic-clonic movements of limbs or loss of consciousness or involuntary passage of urine or stool. There was no frothing from mouth. Mother also noticed breathing difficulty in the child on day 5 of illness in the form of fast breathing, and hence brought the child to SAT. Mother was told by the doctors that the child had breathing difficulty and that the oxygen level in the blood was low, and hence the child was admitted in ICU and started on oxygen support, IV antibiotics and nebulization. There was no history of lethargy, no history of inability to drink, no history of bluish discoloration of skin and mucous membrane, no history of regurgitation of feed, no history of irritability, no history of fever, no history of rash, and no history of any aspiration of feed. After the hospital admission, the respiratory distress improved and the frequency of the movements also decreased. Currently, day 2 of hospital stay, and the child is still on O2 support, IV antibiotics and nebulization. As the child is a case of chronic neurological disease with developmental delay, I would like to start my history from the antenatal period.
Hold on, Anagha. So, madam, we will go by slide by slides or come back after the presentation. How is it going?
Okay, step by step, so that we won't forget anything.
Go with each slide. Okay. You have presented two slides so far.
Okay.
So, what is your current diagnosis for the present admission? What do you think of the cause?
Present admission, sir, child has come with ARA symptoms, cough for 5 days, There was no history of fever associated with this cough. ARI is my present in a primary diagnosis.
By WHO definition, what is ARI?
Sir, ARI, we can, based on IMNC, we can divide it as no pneumonia, pneumonia, or severe pneumonia.
Not like the ARI control program.
ARI is any acute infection of the respiratory tract, duration less than 30 days, and for a year, it is less than 14 days.
Okay. So, for usually we have cough and any child coming with the cough and difficulty in breathing. You have to apply ARI in below what age group?
Generally till 5 years, sir.
So, what is your patient's age group?
It is 7 year, 9 months old.
Okay, so actually by definition you can consider as ARI according to ARI control program. But you can consider some other diagnosis. What is the other diagnosis we can consider for this child now?
I would like to consider it as LRTA maybe because of the nature of the cough.
Okay, that can also be accepted. What is it? You said there is some primary problem. There is no fever for the child. Suddenly, cough and other respiratory symptom. So, did you have any other diagnosis?
I would also like to consider atypical organisms like mycoplasma maybe not presenting with fever.
What about the final year PGs? Manu is he's a madam. She's a second year postgraduate student. He's presenting for the first time. So we can direct questions to the final year MD PGs who is going to appear examination. Dr. Manu, Dr. Anuja, you can all of you can have your name in the okay. Who is available? Dr. Manu? Somebody is available. Final year PG postgraduate students, all are there. Lot of
Justy is a final year student from our side.
Yes, ma'am.
What are the possibilities would you entertain apart from an acute respiratory infection? A developmentally abnormal child presenting with
aspiration pneumonia.
Cough.
Okay, that could be a good possibility than going for aspiration pneumonia. Could be aspiration is a global development delay. Start with the cough. The only thing is there is no fever in the presenting complaint. Even without fever, they can have symptom. Somebody has shown in the chat box as ILA. So will you entertain ILA?
Again, no fever. No fever.
What is the WHO definition for ILA?
Fever for more than 10 days associated with.
Okay, the duration of symptom is less than 10 days with fever 124 degrees centigrade and other symptom. Okay, that could be a possibility. That could be less likely because of this one. So you didn't mention anything in the history regarding the severity of just show the second.
Sir, mother noticed fast breathing. That is why she brought the child.
You should highlight, even though it is a ARI control, it is out of the age. The age is above ARI. You can tell this is tachypnea also.
Fast breathing. But however, mother tells according to her history, there was no lower chest indrawing. And the other danger signs of pneumonia were also not present. That was
not there. Okay. So it could be. So you have mentioned almost all cough. Madam, do you want to have any other questions to be asked? Any other questions?
No.
Yes, madam, you want to ask?
Proceed.
Okay, there's nothing. We can proceed. I think madam's connection is not good. Okay, you can go to the next one.
Antenatal history. Child is a second child of non-consanguineous marriage, spontaneously conceived at 33 years of age. Paternal age at conception was 37 years. Pregnancy was confirmed by UPT after 1 week of missing periods, and she was ANC registered at GMC Trivandrum. First trimester, mother underwent regular ANC. She is a known case of hypothyroidism and was on Tyronorm. Dating scan was normal. Folic acid supplements were taken after the confirmation of pregnancy. There was no history of hyperemesis, no history of fever, rash, joint swelling, or burning micturition. There was no radiation exposure or drug intake.
Hold on, please. Hold on.
Okay, sir.
Previous slide. Okay, so there is a patient is you are telling you are very much concerned about the hypothyroidism. So what is the why you are very much interested in hypothyroidism for this patient? Mother's hypothyroidism.
An untreated hypothyroidism in the mother can affect the brain development of the child.
So Dr. Aradi, when will the thyroid develop in the newborn or in the fetal thyroid develops? Dr. Aradi. Okay. Then you can tell.
12 weeks. 12 weeks.
So what is the change of what are the changes of in the mother's thyroid function test when she get pregnant?
Generally, she is likely to go into her hyperthyroidism during pregnancy.
Hyperthyroidism. So that's anybody else on Silpa? Dr. Silpa. Is she a final year student from Trivandrum? Silpa. Nobody is there in Trivandrum from Trivandrum students. Bindu madam, students are illello.
Sir.
Tell, please tell.
Sir, thyroid.
What are the changes that can happen in the TFT in a patient within a pregnant mother?
Sir,
Okay.
Sorry, increase in the thyroid binding globulin.
Okay. Thyroid binding globulin will be increased. So that what will happen? So
Increase in the
T3 and T4 will increase. Total T4
and T4 will increase.
And free T4 will be less.
Less.
Okay. So what is the role of maternal hypothyroidism for your patient? Okay, the mother is the child is fetus is solely dependent on maternal thyroid. So it is very important to have an euthyroid in during antenatal period. That's the importance why she has asked the question. Okay, so hyperemesis. So what is the permissible radiation exposure that is in during all pregnancy?
5 rad.
5 rads maximum rads. Okay. Joint swelling, fever rash, hyperemesis. Folic acid, you are very much familiar. Okay, go on. Next slide.
Second trimester, quickening was felt at 5 months. Anomaly scan, mother was told that there was some growth restriction in the baby. Iron and calcium supplements were taken. There was no history of gestational diabetes mellitus or gestational hypertension. 2 doses of PT were taken. Third trimester, mother tells that there was a perception of decreased fetal movement since 7 months of gestation. And there is also a history of PV bleeding at 7 months, requiring hospital stay, for which she was given some medications. She had anemia and was on oral iron supplements. There was no history of UTI, no history of leaking membranes, no history suggestive of oligo or polyhydramnios.
Okay, hold on, please. So, what about how will you decide a growth restriction in antenatal scan?
Sir, growth, less than 10 centile appropriate for that gestation.
Okay, intrauterine weight, if it is less than 10 percentile for the gestation age, this hypothyroid, it is a growth restriction. Then
other parameters, the abdominal circumference.
Abdominal girth is below the cutoff value you can consider. Then
crown drum length.
Okay, total round in the first time. So that is not, it is not a, okay. Then what else? Okay, you can fix on these things. Also, our fetal well-being in the form of uterine artery Doppler and also umbilical artery Doppler also indirectly suggests there is a intrauterine growth or intrauterine stress. Okay, so what about the iron? What is NIPI? He's going to tell Parvati KS is Parvati KS is our student. Parvati KS, what is NIPI? Have you heard of NIPI?
National Iron Plus Initiative.
What is the latest development in NIPI?
Sir.
What is the change now happen in NIPI? Is it
Hello.
still existing NIPI, National Iron Plus Initiative?
No, it is now it is anemia book program.
Okay. How many iron tablets should be given all pregnancy?
Minimum 180.
What is the strength of one iron folic acid tablet of pregnancy?
60 mg elemental iron plus 500 microgram folic acid.
Okay, good. Okay, moments, perception of decrease with. Okay, who else is there? Madam, you just, Sreelatha madam, do you have some connection problem, madam?
Am I audible now?
Now it's audible.
Am I audible?
You can say that. You can.
Meka.
Okay, it's not. Madam is not again. Not very much. Okay, so what are the causes of decreased fetal movement in pregnancy? Who else is there? Manu is available now. Manu. So what is the cause of decreased fetal movement?
Decreased fetal movement.
Mother is feeding that decreased fetal movement or causes.
If there is any congenital muscular disorders.
Okay.
Or if the
neuromuscular disorders of the fetus. Fetal cause, then any maternal cause. Maternal. Okay, both polyhydramnios and large polyhydramnios and oligohydramnios. Oligohydramnios mainly, or polyhydramnios both can produce decreased fetal movement, and neuromuscular disorders can have. Then recurring hospital stay was iron supplement, anemia, leaking membrane such as oligohydramnios. What are the, you know what is? Okay. Uterine placenta Pradeep. Okay. So what about the definition of polyhydramnios, oligohydramnios? Pradeep, you can tell. Polyhydramnios, oligohydramnios.
When the amniotic fluid index is more than 25, or when the single vertical deep pocket is more than 8.
Okay. Then oligo.
AF is less than 5 centimeter and single vertical deep pocket less than 2 centimeters.
Sir, Purushottam sir, you want any question to be asked as an member? I am asking as an internal, and madam is an Excel. Madam has got some connection problem. That's why I am leading.
Continue.
Okay, next slide, person. So in between, you can also ask sir questions so that there will be a natal history.
Natal history, mother was taken up for emergency CS at 34 weeks of gestation in view of fetal distress. Breech presentation at birth. Birth weight was 1.3 kg, SJ baby. Did not cry soon after birth. Required resuscitation. Mother doesn't know the details, and child was immediately shifted to NICU and required ventilator support. There was no history of neonatal seizure, no history of neonatal jaundice, no history of neonatal hypoglycemia, and the mother doesn't know if urine and meconium was passed within 48 hours.
Okay, here there is a hold on. Okay, so natal history, there is a some resuscitation. So according to ACOG, what is the definition of birth asphyxia or perinatal depression? Now we will not use the birth asphyxia, we will use the term perinatal depression. Who is Parvati, Babu, already there. Okay, you can tell. What is the ACOG definition?
Meka can answer.
Okay. Anybody I can have. Malavika has already passed the lane. So he become an SR, I think. Asna. What is the definition ACOG? Pamia. Again, Manu.
Sir, cord blood pH less than 7 and the base excess deficit is more than 12. There is evidence of encephalopathy in terms of poor suck and seizures.
Okay.
And there should be UPCAR score less than 3 at 5 minutes, and there should be multi-organ involvement.
Okay. Then what are the this patient is a preterm and need resuscitation. What are the special precaution you will take during resuscitation? You can tell. I think nobody else is not answering. Okay, what else? Who else is there? Okay, this question also you can tell.
Since it is not preterm, the person should be confident in neonatal resuscitation room. There should be cleaned polythene wrap should be present. Things to be present, hypothermia measures should be present, and while holding the baby, also the measures to prevent intraventricular hemorrhage, like a gentle holding, and if we are giving suction, also it has to be minimized, and if we are giving to prevent the bronchopulmonary dysplasia, also try to avoid intubation at the labor room itself. Try to provide minimum FiO2 requirement to prevent the oxygen-induced free radical damage.
Okay, the three important things are temperature maintenance and also decrease the damage to lung or awareness of you can use even neopa for resuscitation rather than going for a bag and mask. Okay, and of course oxygen should be at the lower level. Okay, that's all. Any other question, madam? And ask. Birth weight is 1 K of 3 kg, so it's a low birth weight preterm IUGR. Okay, madam. Sreelatha, madam. I think madam some connection problem. Okay, you can proceed. You can proceed.
Am I audible, sir?
Yeah.
Mother saw the child on postnatal day 4, and the child at that time was on O2 via mask. Feed was started on postnatal day 2. Express breast milk was given via OG. Child was off oxygen support on postnatal day 14. Initially on OG, for later GK feeds were started. However, child had history of feeding difficulty in the form of nasal regurgitation of feed, and the mother also tells that there was a history of abnormal sound while breathing since she saw the child for the first time. During the hospital stay, Shalabam screening was done and it was said to be normal. Head scan was done and the mother was told that there was a fluid-filled collection in the brain, and a repeat scan was advised after 1 month. Child was discharged on postnatal day 17. A prognosis of the child was explained to the mother. She was discharged on supplements. However, after that, they were lost to follow-up.
Okay. So child question. Mother when mother saw child show some strider-like movement, abnormal. Okay. What are the cause of strider? We can tell.
Strider can extrathoracic or intra causes, like we can have laryngomalacia, congenital laryngeal stridor, laryngeal with subglottic stenosis.
Okay. So in the problems that is inherent to the larynx and trachea, then
we can also have retrosternal thyroid and other extra luminal.
okay, same problems can also happen. So here the patient was on ventilator. What is the cause? What are other causes?
Like post-extubation child can
So
develop.
you can have post-extubation side, and also you can consider when you vocal cord injury like that you can have. Okay. Then Salafam screening, you are very well aware. You are not asking any question. And head scan. So what is what about Abhishek? Abhishek is available. What is the neurosonogram protocol for a preterm child? Abhishek. A lot of them.
All units less than 32.
Neurosonogram, when will you do?
32 weeks tall,
depending on the gestation line.
Gestation age.
32 weeks, you had to do it on the day.
Day 1.
Day 3 or day 4. Day 3, day 4.
Then repeat on day 7. Then at 36 weeks.
When the baby is term.
Term.
To look for this one, okay. Then PND 5 okay. Okay. Madam. Sreelatha, madam. Not available, I think. No problem. Okay, Purushottam sir, you want to ask questions?
No, Shanavas.
Okay, proceed.
Post-discharge, mother noticed that the child was not sucking well at breast, and hence she continued to give express breast milk via Gogurna. There was a history of feeding difficulty with prolonged feeding time, a history of inconsolable cry. There was no drooling of saliva. Mother is not doesn't exactly remember the weight gain of the child. At 5 months of age, child attained social smile, was identifying mother and responding to sound. At 6 months, no head control was attained. Going sounds was present. Child would follow objects and turn head to the side of the sound. Mother noticed a stiffness of the lower limbs while changing diapers since 6 months of age. And hence, with the above complaints, she consulted the doctor. She was registered with CDC and advised to do physiotherapy. MRI brain was taken, and mother was told that there were fluid-filled collections in the brain. A neurosurgery consultation was also obtained. However, no intervention was done and not started on any medications. Vision and hearing tests were done at that time. According to mother, it was normal. There was no hand preference or paucity of limb movements. Post this, no further developmental milestones were attained. Child was started on complementary feeding at 6 months of age with ragi and banana powder, which was given with cup and spoon. Later, around 8 months, child was started on rice, which was grounded. Mother gives history of recurrent regurgitation of feeds. A repeat MRI was also taken at 1 year of age, which had the same findings as the first MRI. And she was also referred to physical medicine and rehabilitation for physiotherapy, which was continued till 3 years of age.
Okay, I mentioned about the feeding. So there are some feeding problem. That's prolonged feeding time, and also what else you said? Recurrent
Regurgitation of feed.
Okay, regurgitation. What is it? Simple regurgitation of GER or?
Mother tells that recurrent child was having nasal regurgitation of feed.
So what is the significance of an inconsolable cry?
It is an early marker of
okay, CP. Okay, cerebral palsy early marker could be. What are the other early markers of cerebral palsy other than inconsolable cry? Tell some.
Inconsolable cry, then increased tone, which the mother can notice.
Difficulty in handling the patient,
handling
especially
the baby.
Then
Once the baby starts to crawl, maybe early markers like commando crawling or.
Okay, that's a bit late. Dr. Pradeep, can you tell early markers of cerebral palsy? Okay,
early markers of CP include cortical fisting.
Okay, persistent cortical fisting or thumb.
Absent fidgety movements.
Okay. I already told. Then
rapid increase in head circumference.
Okay, that is a not vision. Okay, so you have to look for that one. If there is some features are there, then social smile at 9 months. At fifth month, I said okay. Head control not attained. Cooing sounds present. Mother noticed stiffness of lower limb while changing the diaper at 6 months of age. So what is it suggest?
Tone abnormalities. Like hypotonia.
6 months with no head control. CDC, MRI brain shows. Fluid filled collections in the brain. So what are the causes of fluid filled collection at 6 months? Isn't it? Okay. What are the causes?
Since it is a preterm baby, we can expect a periventricular leukomalacia and associated cystic cases.
Periventricular leukomalacia, large periventricular leukomalacia may be present as cyst. Other than that, what is the most common cause in a preterm child? Okay, it could be a ventricular hydrocephalus due to IVH. Okay, then subsequently, you can have another thing, porencephalic cyst or ventricular cyst like can be there. Then coronary plexus cyst like that. Vision and hearing tests were non-normal, according to mother. Okay, hand preference not there, no further development by nothing. That was complementary feeding. Okay, nothing. Madam, Sreelatha madam.
When I read the novel, When did they recognize there's something abnormal?
Sorry, ma'am.
Am I audible? Am I audible?
Yes, ma'am, yes.
Ah. When did they identify abnormalities in the baby? At what age?
Mother, according to mother, madam, till even by 6 months, baby was not attaining head control. So that was the first concern that she had. And then later, since 6 months of age, she was also noticing increased stiffness of the limbs and difficulty to handle the baby.
Okay. Okay, again, proceed.
So this baby was a high risk baby, and was she under regular follow-up?
Mother was actually not under a regular follow-up. Since the baby was a preterm,
Not
we expect
mother,
that they might have been
baby.
a baby. Like we would generally review the baby at 4 weeks in case of high risk pregnancy. However, the first review that she went was at 6 months with the baby. So she was a loss to follow-up case.
Anagha. Okay, Sreelatha, you finished?
Sir,
Anagha, this is a case where many high risk factors are there. All the high risk babies need to be followed up for certain things. But this is a situation where after the neonatal discharge, up to 6 months, we lost the follow-up. So everything needed for given during the neonatal period, but that baby was lost at follow-up. So why that follow-up was missed in this situation? Was there any other social reason also need to be improved? Because many other things may not be given, like immunization, whether she got in during this period, may be missing. And as Shanavas rightly pointed out, in any case, all the high risk factors for CP need to be asked for. And rather than stressing on the MRI findings, more important is whether she noticed a larger hair compared to the body. Because fluid documented by MRI may be both ways. A normal head circumference with a fluid inside due to arachnoid cyst or atrophic changes, or a large head with a hydrocephalus.
Mother has not noticed a large head, sir.
Because now you have to depend on the history part only.
Yes, sir.
In the history, there are certain things need to be asked for. What was the feeding method, whether it was gaining weight, there was no documentation, but still you can ask whether the baby was gaining weight on handling the baby. That's
Mother was telling that baby was gaining weight, sir. And for this loss to follow up, according to mother, she is telling that she was asked to follow up at 6 months, but that is not that reliable, sir. I'm not sure about.
This is a second child born with all the care. We will be stressing on all those things because the follow-up of ROP screening, other neonatal screening, all are important. That was missed. Immunization also, you are not sure. Okay, go ahead.
Since 3 years of age, mother noticed increased stiffening of limbs with abnormal bending of the body, and she also noticed abnormal twisting movements of the limbs, which involved both the upper limb and the lower limb. And the baby would assume a posture for few minutes, which was spontaneously resolving, and this was not present during sleep. For this complaint, she also consulted a neurologist. However, her concern was whether it was seizure. She was told that it was not seizure and advised to continue physiotherapy. No other medications were started for this complaint. And according to mother, despite of these complaints, there was no hospital admissions for the same. Child had recurrent regurgitations. However, none of these required any hospital admissions as per the mother.
What do you think of this abnormal movement?
Sir, according to the description, it is like a dystonic movement.
Okay, what is the importance of a dystonic movement for developing in a child like this?
So preterm child perinatal insult can affect the subcortical areas.
Okay, that's why it's developed. What is the importance of further important? How is it? Did you ask anything, any developmental regression or any developmental?
There was no developmental regression, sir. After that, no further milestones were attained. Whatever was attained, there was no regression.
No regression has happened. What is a pseudo regression? What do you mean by pseudo regression?
During the time of illness, baby might.
Okay. Pseudo regression. Okay.
There again, two things. It's clear at this stage that there is an extrapyramidal problem.
Yes.
The commonest of the extrapyramidal problem is a neonatal jaundice, but there was no documentation of neonatal jaundice in this case. So, choreothetotic type of CP due to the kernicterus is not likely. The second possibility, of course, is the sequelae of HIE itself. So, there again, the developmental pattern over the first 6 months to 7 months is so important because the typical choreothetotic CP due to kernicterus will be progressing in a particular pattern where mother will be complaining of the floppiness in the initial part, then only that is the pattern of evolution of the choreothetotic CP. But the other CP need not be like that. There can be a combination of pyramidal plus extrapyramidal, and that can pass on like this pattern. Again, Shanavas sir was asking, when there is an episodic worsening of this thing, another conditions which can present with extrapyramidal, where episodic worsening during infection stress again and again occurring, that is another DD, always CP mimics sometimes need to be considered. Okay.
Yes.
So, Anagha, what made you think it is an extrapyramidal movement rather than a seizure? In this abnormal movement has come up.
According to the description, it is not the regular seizure semiology. There is no uprolling of eyes. There is no tonic-clonic movement. There is no involuntary passage of stool, urine at this time, no frothing from mouth. Mother is only telling about the twisting movement of the limb, and which would spontaneously resolve and not present during sleep, which is why
when there is an extrapyramidal situation, always you need to ask what is the cranial territory also. You mentioned about the limb, upper and lower limb, especially in the lower limb stiffening, and that you mentioned. So we are interested about the feeding and the swallowing part. Many of the situations that will be affected.
feeding difficulty was present, sir.
Feeding difficulty can be multiple ways in a situation like this, spasticity and extrapyramidal. Type of feeding difficulty, you can ask in the history, and that also is important because in the assessment, the functional assessment, one of them is eating and drinking scale. So when you present, that should be like that. You are assessing different ways. The functional aspect also need to be included. Okay.
Okay.
Shall I proceed, sir?
Okay, proceed. Proceed.
There was a history of hospital admission in the month of August 2025. That was the first admission. In view of difficulty in breathing, mother was told that child had respiratory infection at this time, requiring oxygen support. Then the child was shifted to neurology ward, where the child had abnormal posturing, and in view of this, child was shifted to PICU. However, mother was told that it was not seizure. Child was started on some medications for the same. Child did not require any ventilator support during this admission, and for this abnormal movements, child was started on medications. Currently, the child is 7 years, 9 months old. Till now, no neck control has been attained. Child is not able to grasp any objects, no vocabulary other than cooing, able to look and respond to the mother. The child is dependent on the mother for all activities of daily living. There is no seizures, no history of abnormal eye movements, no squint, no facial deviation, no history of decreased sensation to pain and touch, no history of unusual odor of body or urine, no progression or worsening of symptoms over time, no history of sleep disturbance, no constipation, no history of urinary retention. Developmental history. Gross motor, head control not attained. Fine motor does not reach out for objects. Language, cooing sounds present. Social identifies mother. Social smile present. Vision and hearing follows rapidly moving objects. Turns head towards the source of the sound. Based on the history, developmental age is 3 months, around 3 months. Diet history. Child was initially on express breast milk and breastfeeding till 6 months of age. Started on complementary feedings at 6 months. Breastfeeding was continued till 1 year, post which child was started on formula feeds. Now the child is being given family pot diet in grounded form. Egg and fish are included in the diet. Diet is lacking in fruit and green leafy vegetables. Child is getting a calorie of 700 against the required 1270, deficit of 570, and getting a protein of 20 against a required of 29.5, deficit of 9.5 gram.
So what about your eating and drinking scale from the history? How long the child take to feed? Is in choking?
There is history of choking and there is difficulty in feeding. However, child is not requiring any tube feeds. Based on the history, grade 4.
Grade 4. What do you mean by grade 4?
Grade 4 means there is significant limitation to safety and efficiency. However, not required.
Okay. Calorie also is significantly 50% only patient is getting. Okay. Right.
Immunization.
How much calories do you recommend for a child with so much disability who's not ambulant?
2/3 of the required RDA generally for that age according to the recommendation. And I've also decreased the energy requirement for physical activities.
Anagha, you got it?
Yes, madam.
Is it 65% of the expected calories?
Yes, madam. Immunization history. Child is immunized up to age according to National Immunization Schedule. Last vaccine was taken at 5 years of age. There is no history of AEFI. BCG scar present. No optional vaccines taken. Family history. Child is a second child of non-consanguineous marriage. No family history of seizure disorder. No history of abortions or IUDs. No history of sudden unexpected death in family members. No family history of similar illness. No family history of intellectual disability. Socioeconomic history. Lives in Pakka house. 5 family members. 3 rooms. No overcrowding. Mother studied up to 10th grade and she's a homemaker. Father studied up to 10th grade and he's a laborer. According to modified Kuppuswamy scale, belongs to upper lower socioeconomic class, and they are getting monthly pension benefit also, 1,600 rupees per month. Summary. 7-year, 9-month-old female child, second child of non-consanguineous marriage, born as preterm, 34 weeks with very low birth weight, with history of perinatal insult and stormy neonatal period requiring mechanical ventilation. Now admitted with LRTA and increased frequency of abnormal movements which the child previously had. History of global developmental delay. History suggestive of tone abnormalities, abnormal movements. No gross vision or hearing impairment. General examination.
What is the diagnosis from the history?
Based on history, global developmental delay is present. And based on the history, there is tone abnormalities present, so hypertonia.
Hypertonia is not a definition. It is a diagnosis. What is the diagnosis from the history? What are the areas involved? What is the diagnosis from the history? From the history?
Cortical and subcortical involvement since.
Is a diagnosis?
Cerebral palsy.
Static encephalopathy, most probably cerebral palsy. What type of cerebral palsy from the history?
Mixed cerebral palsy, sir.
What?
And subcortical.
Okay, spastic, all 4 limb hemiplegia.
All 4 limbs are involved, sir.
Okay, you can commit like that. So most probably from the history, suggests you global development delay would be static encephalopathy in the form of paralysis with the dystonia. So, could be mixed cerebral palsy on the history. What are the areas involved? We can again tell what are the areas involved?
Cortical and subcortical both.
Okay. Any problems? What are the problems child is facing from the history?
Based on the history.
What about the visual hearing? Is it normal?
Visual hearing grossly normal, sir.
Okay.
And feeding difficulty is present.
Okay. Which is nutritional problem from the
malnutrition, sir.
Okay. Calories very much low. Nutritional intake is very low. Then bowel bladder. History.
Bowel bladder, based on history, there is no constipation, no urinary retention.
Okay, that's okay. Any contracture after examination, you should confirm the history. Any contractures?
Present, sir. Contractures are present.
Okay. Any feeding problem?
Feeding problem is there.
Feeding problem. Okay. So like that, you should consider your problem from the history and also after examinations. Okay, proceed for example.
Comorbidities. All the comorbidities should be elicited.
Okay. General examination. Child is awake with reasonable interest in the surroundings. Posture, lying on the bed. Upper limbs, arms adducted, elbows flexed. Lower limbs, hips adducted, knees flexed. IV cannula present over the dorsum of the left foot, and there is a healed ulcer scar present over the right lower limb. Vitals, temperature 98.4 degree Fahrenheit in the right axilla. Respiratory rate 26, abdominal thoracic. Pulse rate 88 per minute. Normal volume, regular rhythm. All peripheral pulses felt bilaterally equal. No radial or radiofemoral delay. BP 90/60 in the left upper limb in supine position. Saturation 98% on room. No pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. Head to foot examination. Head appears small. Plagiocephaly present. No overriding of sutures. Hair, no alopecia, no color changes. Face, no dysmorphism. There is a loss of buccal fat pad. Eyes, no nystagmus, squint, cataract or signs of vitamin A deficiency. Ears and nose normal. Oral cavity, dental caries present. No angular cheilitis. Oral chewing movements present. Tongue normal. Chest.
What do you mean by oral chewing movement? Is it normal or abnormal? Abnormal oral chewing.
Abnormal.
You think so? Oropharyngeal dyskinesia.
Yes, sir.
Orofacial dyskinesia. Okay. So in that case, what else will you get? Is any drooling?
There is no drooling.
Excessive drooling?
No, sir.
Nothing is here. You are very much interested in color of hair. Why you are very much interested? Color change in the hair. What way it will help? Looking for color change for this patient.
So certain conditions like albinism or Menke disease, we can have hair changes.
Okay. Menke is a problem. You are telling what are the close degenerative disorder or metabolic disorder that will mimic CP that can have hair color, hair changes. You only brought the point of color change in the hair.
Blonde hair.
So somebody is saying malnutrition. Will you consider malnutrition? That is also very important. As a pediatrician, that should be the first diagnosis. Malnutrition. Then mimic, what are the metabolic conditions that mimic CP?
Anemia, sir, IM.
Which are IM? PKU. Then PKU. Already you said about Mengi. Then biotinase deficiency will you consider. One of the close differential we entertain is biotinase deficiency. So you can consider that also. If you want to tell these color changes, okay, proceed.
Tongue appears normal. Chest rachitic rosary present. Harrison sulcus present. Skin no rash, no neurocutaneous markers. Neck no swelling. Abdomen normal. Genital normal female genitalia prepubertal. Spine scoliosis present. No tuft of hair or sacral pit. Limb length discrepancy present. Fingers and toes no asymmetry. No callus, no bed sores.
What is the importance of, just hold on please. You said something there. Genitalia is prepubertal. Are you interested in genitalia in some other way for this child?
The genetic condition.
Okay, somebody has already given. To look for precocious puberty also. You should examine. That's important. You should make sure that there is no precocious puberty. Like, okay.
Anthropometry.
Show the pictures.
Yes.
Why do you show the picture? Okay, what are the abnormalities you are seeing, showing?
Sir, scissoring of limbs present. Then,
Okay, almost hypertonia to the extent that scissoring of lower limbs, upper limbs.
Upper limbs are not so well appreciated in the picture, but contractures present. And
the cortical fisting shown? Yeah, not shown.
Yeah, yes, sir. In right thumb, fisting is present.
Okay, scarring. What is it a scar?
That is from the previous admission cannulation.
IV site,
Yes, sir.
Okay, right, follow.
Anthropometry, weight for age measured 10, expected 23, less than third centile, underweight. Height for age 96 centimeter, expected 122, less than third centile, stunting. BMI 10.9, expected 15, less than third centile, thinness. Head circumference 44 centimeter, microcephaly present. Developmental assessment on 180-degree flip test on supine position, both the upper limb and the lower limbs are flexed. Pull to sit, there is complete head lag. Vertical.
Anagha,
yes, sir.
Go back to the previous slides. Previous pictures. When you assess a child with a significant disorder, global developmental delay or significant disorder, whether it is a static disorder or a progressive disorder, CP mimics can also present like this. Your idea should be what intervention can give benefit to the child. Assessment for the management wise and etiology clues, everything is from the examination. History will tell you the pattern of the development is a regression or a static type of a progressive disorder, and the etiology clues all you will get from the history. From the examination is you are deciding about the management. So everything in the general examination are important. Look at the position apart from the lower limb, scissoring and spasticity. There seems to be neck is a little bit backward. So the spasticity can involve the neck and the spine also. There seems to be a little bit of a spinal deformity and chest deformity also. There is a possibility of a scoliosis and one-sided rib crowding and all are also possible. You said there is a little bit of a ricketic changes.
Yes.
Rickets and vitamin C deficiency are well known in this group that can add on to the deformity part. So assessment from head to foot, the deformity of the bones and joints and skin and the tendons, posture, everything is important for the management part. Okay. So in the eyes, you said vision and hearing. In this case, very difficult to say to what extent the hearing actually is there, what extent the vision is there. So when you are assessing the cranial, you said there is no deviation and all.
Yes,
so what is the pattern of the cranial nerve involvement in a case like this is not a other situation of a structural disorder of one-sided ixol or meningitis sequelae and all. It's usually a bilateral symmetrical. Deviation is not the pattern, but overall bilateral symmetrical usual pattern where eyes are more important. You said the fluid field and all. So eyes, whether there is a downward looking setting sun sign or squint or the movement sideways are normal, is the following is normal. Sometimes ocular posture and the movements are very important. There can be nystagmus, there can be deviation, all those things of the eyes. And drooling, Shanavas for pointing out, in this case, very, very likely that there will be drooling. Because eating and drinking scale is very lower side. When there is no swallowing, definitely there will be drooling. There will be dyskinesia and oro, this thing extrapyramidally is there. So very likely that in this context, dyskinesia also, and the reflex will tell you. The jaw jerk and the other thing will tell you. So general examination again will be needed for many other associated things. Like nutritional assessment is important. Infection, the infestation part is important. neglect is important, hygiene is important. Okay, all are something which you can do something for this child, whether it is a progressive, regressive child or a static child. So all the assessment comes in the general examination. Nutritional disorders need not be protein allergy. There are a lot of micronutrient deficiency. The clue will be from the general examination. So here you said only rickets part.
Yes.
The pallor, vitamin A, you already mentioned vitamin A part. Okay. Okay. Go ahead.
So also, could you notice any abnormal movements during a physical examination? And what was the nature?
Madam, oral chewing movements were present. And also the limb, the twisting movements exactly like the mother is describing, that was noted during examination also.
That again is important. On touching, what happens? How to differentiate in a case like this, whether it is spasticity or a rigidity, whether it is a combination. So there are methods. What happens during sleep? What happens otherwise? Stimulation, what happens?
These movements were not present during sleep, sir.
That is also important. To what extent is the spasticity? To what extent is there a possibility of extrapyramidal? And in the measurement, when you talk about the weight and height, actually it is not height.
Length.
It is a 5-year-old child. These are the situations in which above 2-year also better to tell it as length.
Oh.
And you said there is an asymmetry. That again, measure and you need to prove.
Yes.
There can be an asymmetry because there need not be always bilateral symmetry. There can be some asymmetry that need to be segmental measurement is needed. Okay, it's a length and not a height.
Okay. CNS examination, higher mental function, child was alert and reasonably interested in surroundings. Cranial nerves, olfactory could not be examined. Optic nerve, bilateral pearl, fundus attempted but not appreciated well. Child was fixing onto light, follows bright objects. Visual acuity and color vision not tested. Third, fourth, and sixth.
There again, in the visual part, yes, you need to give a little more of importance because very likely that there can be at least a visual inattention. So we need to see with the pupillary response. In this case, bilateral pupils normal size and reaction is very likely, but very important the fundus part. Is there a primary optic atrophy or retinal changes? Because CP mimics are always, you should keep in mind whenever there is spasticity plus extrapyramidal dot, there is a possibility of this sort of an CP mimics also presenting. The fundus gives the clue. So yes, fundus examination and the light reflex. The light reflex indicate the anterior part segment of the optic. The chart are normal. But one more thing is important, whether there is a blinking menace reflex is important. Okay. Okay, go ahead.
Third, fourth, and sixth cranial nerve, there is no ptosis, no nystagmus, no squint, extraocular muscle movement full in all directions. Fifth nerve, there was no jaw deviation. Jaw jerk could not be elicited due to dystonia, sir.
Again, fifth nerve, we don't expect fifth and seventh or any of the nerve. Jaw deviation or facial deviation is not one thing which you expect in a case like this. Almost this will be bilateral symmetrical. Whether it's a bilateral UMN, many of the cases bilateral UMN of all the clear nerves, what you expect.
Seventh nerve, complete eye closure present, no facial asymmetry. Eighth nerve, child was responding to sound. Ninth and 10th, gag reflex exaggerated, uvula central. 11th nerve, turns neck to both sides. 12th nerve, no deviation of tongue, no fasciculations.
Were there any pooling of secretions in the throat?
Pooling was present, madam. Child, even during feeding, child would hold the food in the mouth for a long time and there was pooling of secretion.
Again, bilateral UMN, you can get the snout reflex, this part, glabellar tap, pharyngeal you mentioned. Yes. Jaw jerk is something when you get above fifth. You get a pharyngeal when there is above 9th and 10th. Okay. And snout reflex you get above 7th. So all these things and the relief reflex, palmar-mental reflex, so all these things are likely in a case like this. It's just of academic interest only, nothing much.
Motor system, bulk, visible severe wasting in all 4 limbs. No asymmetry was noted. The measurements, arm, mid-arm circumference, 14 centimeter right, 14 left, forearm, 11 each, thigh 18 right and 17 left, and leg 12 centimeter each right and left. Limb length discrepancy was noted. Right lower limb measuring 46 centimeter and left lower limb measuring 40 centimeter. Left hip dislocation present. Tone on inspection, there was plantar flexion of bilateral ankle joint, palpation, firm to touch. On passive stretching, hypertonia, spasticity grade 4 in all 4 limbs. There was fixed contracture of left elbow and ankle and bilateral ankle and knee dynamic contractures present.
In the measurement, when you are measuring, when you see suspect an asymmetry, always comment about the comparison of the thumbnails and foot length and two nails. That also, because that is a subtle, most dependable thing. Very easily you can make out the foot length and the nails size. Okay, that you need to mention. And as you said, very, very important thing in a case like this, what is the status of the hip prognostically? Because it is displaced, means nothing much can be done. Very poor prognostic if it is.
Yes.
Should be preventing it somehow, but it is already advanced. That means the lack of care in this case.
Power, best observed power 3/5 in both upper limbs and lower limbs. Reflexes superficial bilateral conjunctival present, corneal not done, abdominal present, bilateral plantar extensor response. Deep reflexes biceps bilaterally 3+, triceps 3+, knee jerk 3+, ankle also 3+, no clonus was present. Primitive reflexes, grasp reflex absent, glabellar tap present, palmar-mental reflex absent. Sensory system, child can appreciate pain and touch. Cerebellum, there was no nystagmus, other cerebellar signs were not tested. Skull and spine, scoliosis present, and there was no neck stiffness.
What is the situation of the hands and fingers? Whether was there any crowding, cortical fisting and the
Cortical
fingers?
fisting was present, sir.
Dislocation was there?
No dislocation. Respiratory system, air entry bilaterally equal, normal vesicular breath sounds heard in all areas.
One more thing, before you shift from the CNS, you need to mention completely. Okay.
Okay.
Like skull and spine, peripheral, in the skull, there was a plagiocephaly. You need to comment whether it is a positional plagiocephaly only or is it having any relevance. Head size is not as increase, on the lower side only.
Lower side.
Shape plagiocephaly ഉണ്ടായിരുന്നു, scoliosis ഉണ്ടായിരുന്നു. In a case like this, when there is a fluid and all, you need to look at the lower back also. Was there any deformity or something there?
There was no sacral pit, no tuft of
Oh, in this case, unexpected because you are getting a spasticity throughout and angle jerk is there. So it's unlikely. Still, you need to mention about that.
Oh. Respiratory system, air entry bilaterally equal, normal vesicular breath sounds heard in all areas, occasional conducted sounds present. A GIT examination per abdomen soft, non-distended, non-tender, no organomegaly, hernial orifice is normal. Cardiovascular system, no cardiomegaly, S1 is to normal, no murmur or added sounds were present. Summary. 7-year, 9-month-old female child, second child of non-consanguineous marriage, born as preterm, 34 weeks with very low birth weight, with history of perinatal insult with stormy neonatal period requiring mechanical ventilation. Now admitted with ERA symptoms and increased frequency of abnormal movements with limb stiffening. History suggestive of global developmental delay. History also suggestive of tone abnormalities, abnormal movements present. No gross vision or hearing impairment. On examination, child has microcephaly, no gross vision or hearing impairment, spasticity in all 4 limbs, weakness of limbs present, brisk reflexes of all 4 limbs, contractures present, bilateral plantar extensor, left hip dislocation, glabellar tap present, chronic malnutrition, signs of vitamin D deficiency is present, dental caries were present, and other systems were within normal limits, and there are no features suggestive of regression of milestones. Diagnosis,
Didn't you get a pseudobulbar palsy features?
Yes, ma'am. Yes. Feeding difficulty and regurgitation is present. That I missed it out in the summary. Diagnosis: static encephalopathy, spastic quadriplegia with dystonia, likely cause mixed cerebral palsy, probable due to perinatal insult, cortical and subcortical involvement, intellectual disability, chronic malnutrition, microcephaly, LRTI, pneumonia, signs of vitamin D deficiency, comorbidities, left hip dislocation, dental caries, scoliosis, feeding difficulty, recurrent regurgitation, contractures, GNFCS grade 5, EDSCS grade 4, MACS grade 5. Other
communication skills also need to be mentioned. Okay.
Okay,
Language communication also is one of the grading. In this case, 0.
Okay. So diagnosis, there is no confusion here. Very well summarized with all points. So static encephalopathy, there is nothing. Spastic quadriplegia with dystonia. Okay. So it's a mixed cerebral palsy. So anybody wants to clarify any of these points? I think this will clearly mention all the things in the patient, all the problems also she has mentioned. Then any differential diagnosis you want to entertain?
Differential diagnosis are structural brain malformations, intrauterine infection, and IAN.
In the assessment questions, sometimes which may be you may be asked to demonstrate in this case, because you have well presented, just like Shanavas said. In this case, you may be asked to present the 180-degree flipping.
Yes.
And what happens in the vertical suspension. Those are the things which are very likely to be, you need to be demonstrating. And the elicitation of the deep tendon reflux, clonus and all. And spasticity assessment like the R1, R2 and all. Because your management wise, to what extent is the contraction, still possibility of a botulinum toxin, is there a need for a surgery? So that decisions are all based on your assessment as an orthopedician. Actually, for the intervention, you need to decide who will be managing. You need to consult an orthopedician or a neurosurgeon and all based on your assessment. So this R1, R2 movement and all are very important. Okay. In the 180-degree flipping also, we'll be asking. In the social part, one of the history point, you said he was getting pension.
Yes, sir.
So we need to know what are the benefits for a child, especially able child.
Yes, sir.
Pension and scholarship and Ashwasa Kiranam.
Yes.
Niramaya. Lot of benefits from the government sometimes may be asked. Okay. Shanavas, you take our continue.
Okay. So differential diagnosis, you have already given some differential diagnosis.
Shanavas.
Okay.
I am Dr. Vijay Kumar.
Oh, sir, please.
And in that, how she diagnosed dislocation of hip, left side?
Please tell.
Sir, left hip, it was internally rotated and adducted, and also the greater trochanter was prominent, sir. Left hip and limb length discrepancy was also left hip short.
So yeah, started with the limb length discrepancy of some 5 centimeters, something like that.
6 centimeters.
Okay.
6 centimeters.
6 centimeters.
Okay. And then subsequently.
It seems there is some hyperpigmented skin for the body, you know, in the picture. Is it because of the picture?
No, mother's.
Is the color of the mother?
Color of the mother is also similar.
So it is their complexion.
Yes.
And when you are having a microcephaly, there will be some hairline abnormality you can see, because the scalp may be normal and you can have a low hairline like that.
No such abnormality is noted, sir.
Okay. Did you palpate for any ridging?
Yes, sir. No overriding. No.
You have to mention. Without mentioning, we will presume that you have no look for it.
Head to foot, I have mentioned, sir.
Bridging, you have said. Okay, this no problem.
So also while mentioning about the postures and all, you mentioned only the arm adducted, elbow flexed, and what about the wrist as well as the hand? Because those are the most important thing regarding the fine motor activity.
Wrist also
fine motor skills.
If the child is
That
having a
should be mentioned.
decorticate posturing, is there is an decorticate posturing?
No, sir. No.
But in the picture, it shows that the upper limbs are flexed and the lower limbs are extended. And your contracture is dynamic or fixed?
The elbow contracture was fixed, sir. Rest of the contractures are dynamic.
Humor sir was pointing out one important point. When you said limb length discrepancy, there are mainly two reasons in this case.
Yes.
One thing is bilateral CNS damage with one side more. There can be asymmetry. And then next reason here is a hip problem. When there is a dislocation, there can be an apparent lengthening situation. So how will you differentiate that? One is clinical features of the dislocation. Second thing is the same side, the hands and the leg. So if it is a central cause, the shortening will be in the upper limb and lower limb also.
No.
There can be asymmetry between the hands and the two nails if it is a central reason for the asymmetry. Otherwise, if it's a hip problem with an apparent lengthening situation, orthopedic situation, it will be restricted to the lower limbs only. Okay.
Now the child is having encephalopathy.
There is no encephalopathy features. The sensorium-wise child was, there was no alteration in the baseline sensorium. Child was active, responding to mother.
Okay.
Can you tell this? There is no encephalopathy. How will be the sensorium of an 8-year or 9-year-old child?
No, so static that encephalopathy is present. There is no.
Your diagnosis itself is static encephalopathy. So there is encephalopathy is there. As compared to the same age patient. Shall we move ahead, sir?
Yes.
Okay. So differential diagnosis, will you consider structural brain malformation in this patient?
Sir, some structural brain malformations can present with spastic quadriparesis.
What is that?
Like
what are the features by which you will suspect a structural malformation?
Sir, imaging wise?
Not imaging, clinical examination.
Clinical examination. Microcephaly.
Parvati case. Parvati case or Parvati? Okay.
Sir, we can look for abnormal head circumference in the child.
Okay. Participant, which one you usually look to suspect a structural brain malformation?
Any spinal dystrophism?
Okay, dysmorphism. Dysmorphism, isn't it?
Yes, sir.
Usually they'll have a dysmorphism and other malformation anywhere else. There is a malformation. Then usually brain malformation, especially neural migration, is associated with the significant seizures, occurrence of seizures. Okay. So usually dysmorphism and other structural malformation anywhere, you should suspect it could be a cause. Okay, will you consider intrauterine infection as a cause of CP for the cell?
Infection was present. Fetal
But
growth,
cell out.
microcephaly, SJ baby.
Okay, the child had oligoamnios from the from birth, from antenatal period itself, and severe IUGR, and patient is having significant microcephaly. But there is no for this only you have to have a detailed examination of the fundus and other organomegaly like that thing. So you can IU infection could be a reason for the static encephalopathy. IEM.
Sir, some IEM can mimic CP like.
Not same for your patient only consider IEM. That's why we are only dealing with our patient.
Less likely, sir. It is non-progressive, and there is no risk.
What are the differential diagnosis of IEM and CP? IEM that manifests as CP. What are the IEMs?
Glutaric aciduria.
Type 2 glutaric aciduria.
Doparis, then arginine deficiency.
Arginine deficiency, yes.
Manages spastic diplegia.
Okay. Like that, so many conditions are also there. Okay, so, Jigumar sir, madam, any more questions in the DD? Shall we? Anything else to be asked? Sir, Purushothaman sir.
No, we'll proceed with the investigation. Sir.
Okay, investigation. How are you going to investigate this child, madam?
So for the present condition, child was admitted with lower respiratory tract symptoms. So for that, we sent a complete blood count and chest X-ray was taken. Chest X-ray only bilateral mild scattered infiltrates were noted, and the counts was also normal with poly and lymph equal in ratio. However, hypoxia was present, so we put the child on O2 prongs and IV antibiotics and nebulization was given for the present condition, sir. Then for the primary underlying neurological condition, first imaging was previously done, sir. Then regarding the management, it is a multidisciplinary approach consisting of physiotherapy, occupational therapy.
So what was the hemoglobin?
HB was 11, sir.
Now your child is having malnutrition,
yes,
and he is getting less than 50% of his calorie.
Yes.
How is having all these parameters are normal? Do you do the peripheral smear?
No, sir. Peripheral smear was not done.
Suppose this child is having leukocytosis and thrombocytopenia with some anemia, but you will suspect.
Infection induced.
Leukocytosis, sir told leukocytosis, thrombocytopenia, anemia.
Any micronutrient deficiencies other than? Suppose he is having B12 deficiency, what you can?
B12 deficiency, we can expect dimorphic anemia, sir. Microcytic anemia.
Total count?
Total count was 10,000.
Now what will happen?
B12 deficiency.
Pancytopenia. Okay. So you have to do peripheral smear also, no?
Yes.
Bilateral patches means it is not aspiration or aspiration.
Sir, no significant patch was present in the chest X-ray only.
Okay, you told something X-ray bilateral patches.
Infiltrates, only mild infiltrates were present, sir, in gestation.
So no
Does
pneumonia.
it increase bronchovascular markings or just patches?
No, interstitial infiltrates are present bilaterally.
What was
So
the
the
calcium?
child is not having pneumonia.
Likely a viral picture about X-ray.
Anagha, in the X-ray, was there any evidence of rickets?
Then, like the wrist X-ray was not taken, sir. The chest X-ray, no other rickets changes were appreciated.
As Vijaykumar sir was pointing out, you need to keep in mind all the treatable entities in a case like this, out of which nutrition deficiencies, all the micronutrient deficiencies are treatable. Nutrition anemias are treatable, vitamin deficiency treatable, D, A, C. These are all very common association in this case. Okay, so hemoglobin, periferous smear, and levels of the calcium. Okay, that's all important, simple treatable things. Okay, so when was the deworming done in this child?
Deworming history,
You need to ask about that because in the management, you may be asked about what are the reason for intractable cry in this child. Okay, all the discomforts like caries tooth, constipation, worm infestation. These are all simple treatable entities.
Okay.
So investigations which are relevant for all those simple things, ear discharge situations, all these things are important.
Okay.
Hip X-ray was taken. Was there a dislocation?
X-ray was not taken, sir.
Because that's a very painful situation. Hip dislocated. So imaging of the chest itself is enough to say rickets. In a case significant malnutrition, sometimes classical rickets features may not be there. For rickets and vitamin C, because there can be pathological fracture if you are not attending to the scurvy or vitamin D deficiency, especially if a patient is being sent for physiotherapy and all. In this case, it's neglected. They may not be doing it.
Yes, sir.
So that can add on to the fracture part also. Okay. Which are the investigation done? You go forward. Imaging done?
Imaging was done during the like when the child was 1 year of age. That was the last MRI that was taken. In that, actually, such cystic changes were present. I did not.
You don't have the film, right?
No, sir, I have not collected the image.
Okay.
What changes you got in 1 year?
Mother was told that cystic changes were present, sir, but I did not collect the MRI.
Didn't see the report.
Yes.
So in a case of spastic quadriparesis, what are the changes, abnormalities that you can encounter?
White matter changes can be present related to the periventricular leukomalacia. There can be a white matter thinning, and associated cystic changes can be present in the ventricles.
Ventricles? Periventricular cysts.
Ventricular.
Can only white matter?
And only white matter. Then if subcortical involvement is also present, the thalamus and the basal ganglia can also be involved. With scarring can be present.
Scarring, cystic changes, all these can be present. Gluco.
Okay. Further management of each problem. What are the problem you are facing for this patient? How are you going to manage?
Sir, first of all, it is a multidisciplinary approach. We need physiotherapy for this child. Then for the spasticity part, we have medical management, like drugs that decrease the spasticity, like baclofen, etc. can be given. Then the child is also having dystonic movements. For that, we can give medications like levodopa, triaxipinidine. Then for the spasticity part, botulinum toxin can also be considered since dynamic contracture.
Really give botulinum toxin?
In dynamic contractures,
They are saying most of them are fast in the not dynamic contractions. So actually, okay, for this, I think this is not a good patient for a already patient that patient
Not a candidate.
Then the hip dislocation has to be managed with bracing.
hip dislocation. What is the cause of hip dislocation? Hip dislocation cause.
Do you think the dislocation can easily be managed in this case?
It will be difficult, sir, since contractures are also.
What is the reason? It is difficult.
Contractures are also present, sir.
Not contraction. Already there is a the already dislocated. So the acetabular
Deformity.
the socket will not be formed properly, and because because of the hypertonic muscle overactivity, psoas and adductor overactivity, already dislocated back. So and there is severe hypertonia also. So because of this reason, it is very difficult to move it back to its original position. So will you try, sir, for this patient?
Sorry, sir.
Purushothaman, sir, Vijaykumar, sir. Will you try for this patient?
This is a prognostically very bad situation. Multiple things need to be considered when a patient is having normal intelligence. So that is the most important thing. How much of the upper story normally remaining, then only you need to do heroic measures for all these things. In this case, whatever you do, the upper story is almost patient is not even recognizing the parents. And what's the point in doing all those things? So,
But when the patient is it's painful, very suffering from pain, then we have to interfere.
Palliatives like measures only.
Okay, other problem?
Other minor management like nutrition and all. So the other management like botulism toxin and surgical management are all, I think, not much benefit.
Spasticity and dystonia.
Yes.
That we have to treat.
That you can do.
The associated comorbidities need to be treated.
Now, what is habit? Physiotherapy. Habit L. Have you heard of that?
No, sir.
Hand arm bimanual intensive therapy, including leg. We can malnutrition part and dystonia, spasticity, all this. We can do something for the patient.
Calorie part, we can build on the calories. Diet can be modified. Then the other conditions like dental caries and all, we can intervene. Supplementation for vitamin D deficiency.
What vaccine you will recommend for this type?
Influenza vaccine can be recommended since there is high risk for aspiration, also recurrent respiratory illness for this child.
Influenza vaccine.
Very similar.
Influenza whether he has taken?
No, sir. No optional vaccines are taken.
It's not optional. All vaccines are recommended vaccines, not optional.
What is Bobat technique?
Sorry, sir.
Have you heard of Bobat?
Bar. Costa.
So all this you should know something. For example, going Parvati, second Parvati case. Babu, Parvati Babu. What is Bobat technique? What is NDT? Neurodevelopmental therapy. So it's a form of neurodevelopmental therapy, Bobat technique. So you are using remodeling. Neuroplasticity as the brain is in the early period, it is neuroplastic. You can use that feature, character for your therapy. The Hoyt also, when we were students, there was a center in Trivandrum for Hoyt therapy. So, madam, anything else, madam? Recent advances. So,
when you're talking about the evaluation of the patient, present, you can classify this as for the present problem. As you already mentioned, you have done CBC, X-ray and all. And then coming to the basic problem, for the etiological diagnosis as well as for the prognosis, imaging, then evaluation of the associated problems, are there the special senses, a formal evaluation of the vision, hearing, then in intelligence. All these things have to come, not this case alone, generally when you're evaluating a cerebral palsy child. So in that manner, you can present investigations of these children. So also when it comes to the management, resort ഓരോ പ്രോബ്ലം ആയിട്ടുള്ളത്, അതായത് ഇപ്പോൾ സ്പാസ്റ്റിസിറ്റി എന്ന് പറയുമ്പോൾ ഫിസിയോതെറാപ്പി ആൻഡ് ഡ്രഗ്സ്, dystonia drug, and each problem, behavioral problems ഉണ്ടാകാം. അതിന് അങ്ങനെ ഓരോന്നായിട്ട് പറയുവാണെങ്കിൽ നമുക്കൊരു കംപ്ലീറ്റ് കോംപ്രിഹെൻസീവ് ആയിട്ടുള്ളൊരു മാനേജ്മെന്റ് ആയിട്ട് നമുക്ക് പ്രസന്റ് ചെയ്യാൻ പറ്റും.
Okay.
How early you can diagnose a cerebral palsy?
As early as 2 to 3 months, like early markers of CP we can consider.
In newborn, is it possible?
Newborn, like inconsolable cry or any such early markers are present, we can.
A neurological examination will give some clue.
Tone abnormalities can be present.
So have you heard of Heinz?
Hammersmith.
neurological evaluation.
So the gross moment abnormalities or mass moment abnormalities will again tell that there is some problem for the baby. Even from there itself, you can understand there is a problem. Is there any difference between release reflex and neonatal reflex or primitive reflex?
Not sure.
Is one and the same, or which condition will you look for release reflex?
ജസ്റ്റി പറഞ്ഞോളൂ, ജസ്റ്റി പറയും. എക്സാം ഗോയിങ് ആളുകളൊക്കെ പറയാം. മേഘ, നീതു, ആരും മിണ്ടുന്നില്ല.
9 മണി കഴിഞ്ഞില്ല.
ഡൗൺ ആയി.
Okay, let's just we can have a comment from these examiners and wind up.
Anagha, you did very well. Okay, second year student, so the performance was good, and many of the other students also performed well. Others, Arana Vijayamar son, your son?
Others, another question ചോദിക്കണം വിചാരിച്ചാണ്. മറന്നുപോയി.
അത് ലാപ്ടോപ്പ് ഈ